Charles, sir.
Yes, okay.
Yes.
Yeah, I'll request the tech support to go back to the first few slides, our introductory slides. So good evening, everybody. Welcome back to the new edition of the postgraduate psychiatry lecture series, the revamped lecture series. And we are very, very pleased to have with us Dr. Nilesh Shah for a chat today with us, and he will talk to us about ketamine. And we are very privileged to have with us Dr. Deepak Tiwari. We apologize again for a little bit of the delay, and we will try and make up for lost time. But I'm sure Dr. Nilesh Shah is always a popular person. Everybody wishes to hear him, and he's always been a great academician, a great teacher, and he's inspired many of us, and I'm sure his pearls of wisdom today will inspire us as well. And I take this opportunity to introduce to you Dr. Tiwari. Dr. Tiwari is the professor and head of Department of Psychiatry at the GG Medical College and Hospital, Jamnagar. And he's been the head of department for about a decade now. He has been the additional medical superintendent of the hospital as well. He's obtained his degrees from Bhavnagar as well as Jamnagar and PJ Medical College. He's been a very good teacher and a inspiration to many of his students. And we are very happy for him to have taken the time and kindly consented to be a part of this program. I will request him to put in a few words and give us an introduction of Dr. Nilesh Shah. Dr. Tiwari, you have Dr. Nilesh Shah's introduction with you now. I hand over the proceedings of the evening to you, Dr. Tiwari, and I shall step in back at the end of the Q&A.
Thank you, Nilesh. Good evening, Nilesh Shah, sir, and all respected members who are there and students. Dr. Nilesh Shah, sir, when we saw him first time in Ahmedabad, like I was a student. So I think I again will become a student, and he has been a mentor in many ways. He has been a role model for a number of psychiatrists, and this is a very interesting topic. We have used this drug in 2 patients in emergency. So we would be looking forward to listening to Dr. Nilesh Shah, sir. He definitely does not need any introduction in West Zone. Sir, the stage is yours, please.
Thank you very much, Dr. Tiwari, Dr. Rashmin Cholera, for nice words. And I'm grateful to all of you and Dr. Rashmin Cholera and the whole PG committee of Indian Psychiatric Society for inviting me and giving me this opportunity to present on this unique topic, which we call ketamine, an antidote for suicidal thoughts. Can I have the next slide, please? Yeah. So we go to Belgium in circa 1960. Next slide. So ketamine got its start actually in Belgium in 1960, almost 40 and another 25. So 65 years ago, actually they started using ketamine as an anesthetic agent for animals. Prior to that, they were using psilocybin. But psilocybin was creating lots of problem, delirium, confusion. So they found that ketamine was more safe than psilocybin. So they started using in 1960, way back in 1960 in Belgium, they started using ketamine as an anesthetic agent for animals. Next. 10 years later, if you see, in Vietnam War in 1970, they started using ketamine as a buddies drug. So soldiers were given this medicine to keep in their bag, and if a soldier is injured at the battlefront, at the battlefield, before they transfer the soldier to the base camp for medical help, to reduce his pain, they started giving this ketamine injection at the battlefield. So wherever he is fighting the battle and he gets injured, the buddy, the second soldier who carries the ketamine with him, he'll remove the ketamine and inject him to reduce his pain. And the only reason where they started using ketamine, because they found that ketamine is the only anesthetic agent which does not cause any respiratory depression. Other anesthetic agents cause respiratory depression. So if you have to use it on battlefield, you have to use something where there should not be any respiratory depression. So if some soldier is injured, the buddy, the next soldier will inject him with ketamine, the pain will go down, he will feel much better, and then he will be transferred to the base camp for further medical care. Next. So it was used in treating injured soldiers on the battlefield in the Vietnam War. Next. 10 years later, in 1918, Yale University, they started actually investigations on ketamine to produce symptoms of schizophrenia, because they realized when you inject ketamine very fast, the person develops a dissociative state and he starts behaving in a little abnormal manner. He starts getting hallucinations, and there is a phenomena where he feels he is double kind of thing, separated from himself. So they felt that these were symptoms similar to schizophrenia. So if you want to test any drug, what you do, you induce schizophrenia and then give that medicine and see whether those symptoms are reversed or those symptoms are prevented. So in 1980, there was a further advance where ketamine was used for inducing symptoms of schizophrenia in volunteers. Next. And bingo, 1990, New York. This was the year which changed the ketamine. The emergency responders may give ketamine to an agitated patient who they have rescued from suicide attempt. At that time in 1990, there was a fashion that people will go on the bridge and jump off into the river to die. That was a common method of suicide. So if somebody is going to jump off the bridge and people hold him and they call for the help, and this emergency responders, a kind of police, would come over there and then they will save these people. But these people are very aggressive, violent. They want to jump off the bridge. They are terribly depressed. They are suicidal. So they want to jump off the bridge and kill themselves. So at that time, what used to happen, that if someone is trying to jump off a bridge and they give him ketamine in the ambulance to calm him down, and 9 months later, he says, I haven't felt suicidal for 9 months. Now, this was a miracle. A person who was going to jump off the bridge in New York, the public over there holds him, prevents him from jumping, calls the emergency responders, emergency police comes, they pick him up, and just to restrain him, he is injected with ketamine. Again, because ketamine does not cause respiratory depression, the person gets sedated and then he is taken to the hospital. In hospital, he is admitted for 2-3 days. They talk to him, they start antidepressant, but they see that within 2 days, within few hours, in fact, his suicidal ideations disappeared And it remained like that for 9 months, no depression, no suicidal ideations. So people started wondering that what's happening. And that's how doctors began to realize that the drug had powerful effect against depression and suicidal thoughts. So next, people started wondering, can we really use ketamine? Yeah, next slide. So with this, people started wondering, can we really use ketamine for the treatment of depression? And then actually use of ketamine started, and we started getting papers on ketamine in prestigious journals. Next. So you see one of the first publication. Next. Yeah, you see one of the first publication in circa 2000. This was published in Biological Psychiatry. And from 2000 to 2013, in different parts of the world, they started using ketamine, and number of studies, number of short cases, series of cases, they were published in various journals. You see this publication in Biological Psychiatry in 2000 by Robert Berman, and he had 7 subjects with major depression, completed 2 test days that involved intravenous treatment with ketamine hydrochloride, 0.5 milligram per kg body weight or saline solution. So it's a kind of comparison study with ketamine versus saline solution under randomized double-blind conditions. And next, the results. Subjects with depression evidenced significant improvement in depressive symptoms within 72 hours after ketamine, but not with saline solution, that was a placebo. So these results suggest a potential role of NMDA receptor modulating drugs in the treatment of depression. So way back in 2000, they realized that it's a potential candidate for treatment of depression. And they also knew that it is an NMDA receptor antagonist. The fun is that actually the effect of ketamine, the antidepressant effect of ketamine, the anti-suicidal effect of ketamine may not be because of the NMDA receptor antagonism, but because of the potentiation of EMPA receptors. And now we realize that what NMDA receptor antagonist is actually not the real mechanism of action. It may be EMPA receptors stimulation, which has an antidepressant effect. Subsequently, in 2006, 2 case studies of patients with major depressive disorders, they were given low dose ketamine. Now the standard dose of ketamine intravenous infusion was 0.5 milligram per kg body weight. But these people showed that even the lower dose of 0.27 milligram per kg per hour was effective. So they have published these 2 cases in pain medicine. One patient had 18 months history of depression, and it was unsuccessfully treated with citalopram, mirtazapine, venlafaxine, and DCT. She was given 5 days course of ketamine intravenous at 0.27 milligram per kg per hour. Her BDI score improved from 36 to 11 in 4 days, and she remained well 12 months later on citalopram 40 milligrams. A treatment resistant to citalopram, mirtazapine, venlafaxine, and ECT responded and remained better for 12 months after ketamine. Next, the second case, again published by the same authors. The second patient had 16 years history of depression, unsuccessfully treated with fluoxetine, nifazodone, mirtazapine, venlafaxine, amisulpride, lithium, and ECT. See the treatment resistance. And he was given a 5-day course of ketamine IV 0.3 milligram per kg per hour, and his BDI score improved from 52 to 9 in 4 days. Remarkable improvement and rapid improvement, which was never seen with medicines in the past few years. And earlier, they were giving only 2 doses of ketamine. Here, the authors have given consecutive ketamine for 5 days. And nowadays, even sometimes when we use intravenous ketamine for rapid improvement, we give ketamine every day for 5 days. This patient relapsed twice, once after 2.5 months and another after 3.5 months, and had 2 further 5-day infusions which were successful. So it's not that patients do not relapse once they are treated with ketamine, but even if they relapse after 2 months, 3 months, 8 months, you can use again 5 days course of ketamine and patients will rapidly improve, and then you can maintain them either on antidepressant or on lithium. This patient at 12 months remained well on lithium 500 milligrams per day. Next, so here they realized that ketamine is not only useful in treatment of depression, but also very, very useful in treatment-resistant depression. 3, 4, 5 antidepressants in combination with ECT, patient not responding, 5 days course of ketamine and patient response, not only responds but remains and can be maintained on 1 or 2 antidepressants for next couple of years. So then they planned a randomized trial of NMDA antagonists in the treatment-resistant major depression. See, up till now, they are feeling that it is NMDA receptor antagonist, and that myth that it is NMDA receptor antagonist continued even when they prepared enantiomer of ketamine as ketamine. A randomized placebo-controlled double-blind crossover study of 18 patients with treatment-resistant major depression given a single intravenous infusion of ketamine, again 0.5 milligram per kg over 40 minutes. This procedure, giving ketamine intravenously 0.5 milligram per kg body weight over 40 minutes, then onwards became a standardized procedure. And see the response. 71% met response criteria the day following ketamine infusion as compared to 0% subjects treated with placebo. You might have read many antidepressant trials with placebo with a comparison agent, and nowhere you have seen this kind of difference in one day, 71% versus 0%. Most of the trials you will say drug was useful in 45% of the patient, placebo was useful in 30% of the patient. The difference between placebo and antidepressant drug over a period of 6 weeks or 8 weeks or 12 weeks would be around 10 to 15% based on which we use that antidepressant. Here, ketamine given as a single intravenous dose and next day you see 71% improvement as compared to 0% improvement with placebo. So then people started using ketamine more and more frequently, and more papers started coming up from different parts of the world. Next. And this is again Swiss Medical Weekly, a 55-year-old male subject with a treatment-resistant major depression and a co-occurring alcohol and benzodiazepine dependence. So now, because they found that ketamine is useful in depression, they also started using in more complicated cases where you have depression with substance use disorder. So this gentleman not only had treatment-resistant depression, but also had alcohol and benzodiazepine dependence, and he was treated with intravenous infusion of same 0.5 milligram per kg body weight of ketamine over a period of 50 minutes. Over the previous 5 years, the subject had been treated with citalopram, paroxetine, myosin, mirtazapine, venlafaxine, triimipramine, trazodone, and escitalopram. You name a drug and they have given it. Also, next, it was augmented by methylphenidate, valproic acid, lithium, olanzapine, quetiapine, buspirone, and chlorpromazine. And he had not shown improvement. So see the amount of resistance this patient had. And throughout 2002, the subject had received even cognitive behavior therapy. All of these were tolerated, but failed to achieve remission. And see the response with ketamine. After the ketamine infusion, his BDI score from 26 went down to 9 in 2 days. Isn't it very, very impressive? So then they started giving serial infusions. So serial infusions of low dose ketamine for major depression. So in Journal of Psychopharmacology in 2013, they published this case. 10 depressed patients were treated with twice weekly ketamine infusions of ketamine 0.5 milligram per kg administered over 100 minutes until either remission was achieved or 4 infusions were given. And side effects were assessed with the Young Mania Rating Scale to see whether does ketamine cause a switch into mania, and also whether it causes psychosis. So even a brief psychiatric rating scale was used. And patients were followed up naturalistically at weekly intervals for 4 weeks after the completion of the infusion. Next, and they found 5 of these 10 patients achieved remission status, complete recovery. There was no significant increase on BPRS or YMRS score. So no psychotic symptoms, no manic symptoms. 2 of the remitting patients sustained their improvement throughout 4-week follow-up period. Ketamine infusion at a lower rate than previously reported have demonstrated similar efficacy and excellent tolerability, and may be more practically available for routine clinical care. So they concluded that serial ketamine infusion appear to be more effective than the single infusion, because the effect of single infusion, though have remained in some patients for longer period of time, in most of the patient, it may remain only for few days, maximum 1 week. So now they started giving serial infusion on twice a week basis for 4 weeks. And obviously they have suggested that further research to test relapse prevention strategies with continuation of ketamine infusion was indicated. And now we come to India, our own country. Sare jahan se acha, Hindustan hamara. We have started using intramuscular ketamine in acute depression. And these 2 case report, this report of 2 cases was published in our own Indian Journal of Psychiatry by Harihar C, Dasari P, and Srinivas JS. In 2013, 10 years back, they have started using and publishing reports on ketamine from India. A 23-year-old male with OCD for 5 years on fluoxetine 40 milligrams for bupropion 300 milligrams attempted suicide by slashing his throat. His bupropion was hiked to 450 milligram and fluoxetine to 60 milligram. Obviously, many of us think that fluoxetine is SSRI, it will increase serotonin, and bupropion is NDRI, norepinephrine dopamine reuptake inhibitor. So that will increase norepinephrine and bupropion. So that combination is used. And here he had severe depression, a patient of OCD, severe depression, tried to kill himself by slashing his throat. So he was given injection ketamine 0.5 milligram per kg body weight intramuscularly. He had no side effects. Next. After 2 hours of just giving intramuscular injection, 2 hours, his HDRS score dropped from 21 to 4. 3 days later, he received similar dose. His HDRS scores dropped from 10 to 7 within 2 hours. The effect was seen within 2 hours in a suicidal patient. During the subsequent weeks, the improvement was maintained and suicidal thoughts never returned, as it was shown in patients in New York. He appeared in his examinations and did well to his satisfaction. No cognitive side effects as we would have seen with ECT. They have also published this second case. A 21-year-old male suffering from recurrent depressive episodes since 5 years reported recent worsening of his symptoms along with suicidal ideations. He was on bupropion 450 and fluoxetine 20 milligram. As he was not willing for ECT, he was taken up for ketamine. Nowadays also, if patients are not willing for ECT, one of the options is ketamine, which may be as effective as ECT. So in emergency situation, if you can't give ECT, you can try ketamine. Next, a dose of 0.5 milligram per kg of IM ketamine was given. And as expected, within 2 hours, his HDRS score dropped from 21 to 6. He did not have any side effects. After 3 days, he was given a second dose of ketamine. After 2 hours, again, the score dropped from 13 to 6, 50% reduction. He reported little nausea, which subsided with oral domperidone. One of the common side effects which people have noticed with ketamine is little nausea. And if the patient gets nausea or vomiting sensations, one can use domperidone or ondansetron, the typical what we use for preventing vomiting. So first time in 2013 in American Psychiatric Association, which happened in San Francisco, California, they published this ketamine for treatment-resistant depression in OCD. And these authors actually presented these things next in conference in American Psychiatric Association. 72 treatment-resistant patients with depression did not have any improvement after trying at least 3 different biological treatments, were either given an intravenous infusion of ketamine for 40 minutes or an active placebo, midazolam. Here, instead of giving IV saline, they have used midazolam to see whether it's a sedative effect of the ketamine, anesthetic agent of the ketamine which works, or it's something else. So midazolam was used as an active placebo. And after 24 hours, 63.8% of ketamine group had improved symptoms compared to 28% of placebo group. 7 days later, 45.7% of the ketamine group still had improved symptoms compared to only 18.2% of the placebo group. Neither group had any major side effects. This is in American Psychiatric Association. They also tried in OCD, treatment-resistant depression and obsessive compulsive disorder. And a second trial in 15 patients diagnosed with obsessive compulsive disorder conducted at Columbia University in New York City found that drug was significantly superior to placebo than the saline in this case in reducing OCD symptoms. According to Yale Brown rating scale and patient self-assessment, both there was a significant improvement. Next, this. Neither group, both the studies were reported here at the American Psychiatric Association annual meeting. So, ketamine became more and more popular, and now we come to circa 2020, almost 3 years back. Next slide. Efficacy of single and repeated administration of ketamine in unipolar and bipolar depression. And now we started getting meta-analysis of randomized clinical trials. See, people have started doing so many trials and then you put together and do the meta-analysis. So by 2020, we had the meta-analysis, and this was a report of the meta-analysis. Our meta-analysis revealed rapid and robust antidepressant effects of single-dose ketamine in patients with treatment-resistant depression. By pulling data from randomized controlled trials, RCTs, we showed for the first time that repeated ketamine administration is effective in sustaining initial antidepressant effect observed after single dosing. So both the things, single dose rapidly shows improvement and repeated infusion of ketamine maintains the improvement over a period of time. So people started using it in unipolar depression, and the question started coming up, can we also use ketamine in bipolar depression, IV or oral? Next. So ketamine for bipolar depression, and they have already treated so many patients that we have now a systematic review of ketamine in bipolar depression, circa 2021. The authors identified 6 studies with 135 patients. All studies use 0.5 milligram per kg of add-on intravenous racemic ketamine with the number of doses ranging from 1 to 6. Some people received 1 infusion, some people received 2, maximum was 6. All participants continued a mood stabilizing agent, can be lithium, lamotrigine, valproate, whatever they were on. The overall proportion achieving a response, defined as those having a reduction from their baseline depression severity of at least 50%, which is a standard criteria, was 61% for those receiving ketamine, as opposed to only 5% receiving placebo. See the difference, 61% against 5%. Next, the overall response rates varied from 52% to 80% in some studies. Ketamine was reasonably well tolerated. However, 2 participants, one receiving ketamine and one receiving placebo, developed manic symptoms. So you can always argue that yes, ketamine can cause manic symptoms in a depressed patient, but even placebo also caused the one switch into the manic. So whether it is because of medicine or whether it's a spontaneous switch, it is difficult to say. But then yes, if somebody says, we can agree that yes, ketamine can also cause a switch into mania. Some participants also develop dissociative state at 40 minutes mark following ketamine infusion in 2 trials. So one common side effects, I said that it causes little nausea and vomiting. And another, if you give rapidly, the patient may develop little dissociative state, little confused kind of thing, hallucinations, that kind of thing. We are using ketamine for almost now more than 5 years. After this 2013 case published in Indian Journal of Psychiatry, we were encouraged. And now, initially we were giving intravenous ketamine, but now we have started using only oral ketamine. No intravenous ketamine, as we found that oral ketamine is as effective as intravenous ketamine, and it is very, very easy to administer oral ketamine. You don't need anesthetics, you don't need any investigations. You can easily do it as an OPD procedure, or after doing OPD procedure once or twice, you can also ask the patient to drink ketamine at home. The way you give medicines at home, patient can drink ketamine in a juice at home. So this case, our own case, a 42-year-old female, case of bipolar mood disorder, was on lithium, lamotrigine, escitalopram, presented with severe depression and suicidal ideations. So ketamine, nowadays we use it for these 2 indications, one treatment-resistant depression and one in emergency situations to take care of suicidal ideations. Mirtazapine 15 milligram at bedtime was added as patient had insomnia. He was a bit reluctant for ECT. ECT is the best gold standard. We recommend ECT to all the patients who come with suicidal ideations. But if they are reluctant for ECT, the second best option is ketamine. He was willing to try out ketamine, so we started him on ketamine therapy. So how do we give this ketamine therapy? Next, this is about oral ketamine therapy, which all of us can use in any patients who have severe depression, treatment-resistant depression, depression with suicidal ideations. So what we do, we gave him 100 milligram of ketamine, that is 2 ml. Ketamine is available as 50 milligram per ml concentration in a vial. You can get 2 ml vial, you can have 5 ml of vial, you can have 10 ml vial. So easy is to get a 2 ml vial. We break it open, that is 100 milligram of ketamine. We put it in 300 ml of juice. We mix it and ask the patient to drink it gradually over a period of 45 minutes. That's it. We monitor the pulse and blood pressure at baseline before starting the drinking of ketamine. After 15 minutes, after 30 minutes, after 45 minutes. And we monitor pulse and blood pressure. And we find in most of the patients, they felt immediate relief in depressive symptoms and suicidal ideations. Now, this single oral ketamine, when brings about the improvement, that improvement needs to be maintained with subsequent doses of ketamine. Because if you stop the ketamine after first dose, he may again relapse and symptoms might come back. So what nowadays we do, we continue this ketamine oral therapy 3 times a week. That is Monday, Wednesday, Friday for first 2 weeks. Then we give it twice a week, Monday, Thursday for third and fourth week. And then we reduce it to once a week, that is only Monday and Monday for fifth and sixth week. So Monday, Wednesday, Friday, week 1, week 2, Monday, Thursday, week 3, week 4, and Monday, week 5, week 6. And we noticed that improvement was maintained for long time. So this is a standard procedure which we nowadays recommend for ketamine treatment. It can be done anywhere. You can do it in your OPD. You can do it in primary health center. You can do it at patient's home. After you do it 2-3 times in your clinic, you can also ask the patient with one informed relatives to do it at home. So ketamine therapy has become as simple as that, as safe as that. Next. Some of my friends and colleagues had this wonderful idea that ketamine is an anesthetic agent and ECT is also very, very effective treatment for treatment-resistant depression, major depression, psychotic depression. So can we combine ketamine and ECT? So instead of pentothal or propofol anesthesia, why not give ketamine as an anesthetic agent and then give ECT? Has anybody done like that? And yes, we have a case report on that. Next. It was a very interesting case report. As you see, antidepressant effect of ketamine during ECT. And authors, it has published in American Journal of Psychiatry in 2005. And they have written it as an opportunistic case report. An opportunistic case report of a woman with severe treatment-resistant depression who was referred for ECT shortly after ceasing anti-epileptic drugs. She was given ketamine as an anesthetic agent for the ECT, but failed to have a convulsions on 2 successive occasions. In spite of this, she experienced an immediate and unexpected improvement in her mood both times. Later on, they found that ECT machine was actually not working. And that's why even after pressing the button of the ECT machine, patient was not actually getting the convulsions. And in spite of that, patient improved. And they realized that it was not the ECT, which actually was not administered, but it was a ketamine, which was given as an anesthetic agent, brought about the improvement in the depressive symptoms. So they have done a trial on this next. rapid antidepressant effect of ketamine anesthesia during electroconvulsive therapy of treatment-resistant depression, comparing ketamine and propofol anesthesia. So now, if your anesthetist buddy is willing, you can tell him that whether he will be willing to give ketamine as an anesthetic agent rather than propofol anesthesia. And I'm sure he will be more than happy to give ketamine because ketamine is more safe than propofol. Ketamine can be given in OPD. Dentists use it for tooth extraction in children. They give ketamine injection, the child sleeps. It has an anesthetic agent and he can easily pull out the tooth and no respiratory depression, no fear of respiratory depression. That's safe ketamine is. So 31 patients, and again, a very prestigious journal, Journal of ECT 2010, they have published this, 31 inpatients with treatment-resistant depression. An anesthesiologist who was unaware of the mental symptoms of the subject assigned them to receive either propofol or ketamine anesthetic agent according to the preference of the patients, and the patients underwent 8 ECT sessions for 4 weeks. Next. And see, the HDRS scores improved earlier in ketamine group with decrease in HDRS scores that was significantly greater in ketamine group. The results suggested that it is possible to improve symptoms of depression earlier by using ketamine anesthesia. We had one patient who was given 12 ECTs and had not shown much improvement. We started him on ketamine and we gave 12 ketamine sessions. At that time, we were using intravenous, so we give intravenous ketamine session and not much improvement. And then we thought that let us combine two, like we combine two antidepressants. We gave him ketamine anesthesia and ECT and he started improving. The difference which you see in ketamine anesthesia, ketamine is given as a bolus rapidly, while in ketamine infusion, we give it slowly. Or oral ketamine, we ask them to drink it over 40 minutes, 45 minutes. So probably that is the difference when you give ketamine as an anesthetic agent and when you give ketamine as an infusion or oral. So finally, when I have told you so many good things about ketamine and all of you would be willing, and many of you have already started using ketamine in your patients. As Dr. Tiwari said that he has already tried it in 2 patients, and I am sure many of you also must have started ketamine in few patients. What you would be asking me is about safety and tolerability. So next, let us look at the safety and tolerability of ketamine treatment. Next. So let us look at safety and tolerability of ketamine treatment. Next. So here is a paper targeting the glutaminergic system to develop novel improved therapeutics for mood disorders, published in 2008 in Drug Discovery. Clinically, ketamine is popular agent for emergency department procedural sedation in children, with ample evidence to support its safety and efficacy. Although its psychotomimetic side effects have led to its misuse and abuse, there is no evidence that ketamine causes physical dependence in humans. Next. In addition, recent studies found no evidence that repeated exposure to ketamine increases the risk of more severe or more protracted psychosis, perceptual changes resembling dissociation, severe emotional distress or euphoria in healthy subjects or in patients' population. People have been using now ketamine for more than 20 years. I told you the first case reports of 2000. And after 2000, we are in 2020, so more than 20 years, and nobody has reported a single case of ketamine dependence after starting the ketamine therapy for depressed patients. Next. psychiatric safety of ketamine in psychopharmacology research. This is in 2007, Journal of Psychopharmacology. 450 subjects received at least one dose of active ketamine. In 833 subjects, active ketamine and 621 placebo infusion were administered. 10 adverse mental status events were demonstrated in 9 subjects. The side effect was noticed in 2% of the subjects. 2 out of 100 people had some side effects that were deemed related to ketamine administration. All but one adverse reaction resolved by the end of the test session. So if you are drinking ketamine or if you're giving IV ketamine and person develops some hallucinations, some dissociative states, some unusual experiences, you stop the infusion or you ask the patient to drink ketamine slowly or stop it for 5 minutes and again start. Immediately, as soon as you stop ketamine, the adverse reactions resolves and patient would be absolutely fine. So now coming to 2013, present day Indian Sarkar, 2013, next slide. The status today. So what is the situation today in India? Some psychiatrists are already using ketamine for selected patients. As I said, most of the treatment resistant patients and patients who indulge in suicidal ideations. It is used intravenously. I know many psychiatrists who are using intravenously. There are psychiatrists who are using intramuscularly and subcutaneously. We are using orally, and there are some psychiatrists who fill this ketamine in the canister and then use it intranasally. Again, like S-ketamine, which is available in USA. Doctors can do this legally because ketamine is an FDA-approved anesthetic drug. The rapid short-term benefits in suicidal patients and high benefit in treatment-resistant depression might outweigh the risks associated with its use, which is absolutely minimal. Before I end up and say goodbye to all of you, one major disaster which has happened in ketamine treatment is S-ketamine. So many years they thought that ketamine is an NMDA receptor antagonist, and that's how they tried to use S-ketamine instead of racemic ketamine, which is a R-ketamine and S-ketamine, two enantiomers. S-ketamine has 3-fold greater affinity for NMDA receptors. So they prepared S-ketamine thinking that that would be more effective than racemic ketamine. They started using it and they found that it was not as effective as racemic ketamine. And then they realized that the actual effect of ketamine is not because of NMDA receptor antagonist effect, but its effect on EMPA receptor potentiation. And R-ketamine has more effect on EMPA receptors than S-ketamine. So this was a major blunder, and we had conducted this session in our recent conference. We conducted actually a workshop in Indian Psychiatric Society annual conference where a psychiatrist from UK had come, and he also said that in UK also they have observed that ketamine, which is quite cheap and easily available, is superior to S-ketamine, which was terribly expensive, which only less than 1% of the population can afford, is less effective. S-ketamine is less effective than our racemic ketamine, which is reasonably priced. So with that, my last slide. Thank you very much. And I'm signing off. I'm a member of Ketamine Fan Club, like many of you. Thank you very much.
Thank you, sir. What a wonderful way. Again, so many stories we heard about ketamine. Sir, recently today, because I thought I will become a good student, so I read in BMJ recent, there was a publication that it also reduces suicidal ideas immediately. So almost like you saw the photo you showed us from the bridge. So I'll request questions to all the participants who have been hearing, delegates. Please ask questions to Nilesh Shah, sir. Dr. Rashmin, sir, are we doing okay? Like,
Yes, yes, absolutely fantastic. I couldn't ask for a better session.
yes, sir.
I will request all the participants to put their questions in the chat box.
So last patient, by the time we are waiting for questions, sir, one of the last patient was very lean and thin and was suffering from severe depression, as well as has had some cirrhotic element, not to that extent that it was in severe grading. And fortunately, LFT was normal. He improved to a significant extent and he could go to uh, his shop. So that was the, like, we didn't say see a sea change, or probably more than 50% of the depressive syndrome improving. So this is last experience which we saw had recently. They were not ready for ECT. Even now, like, he's still having 50% or less improvement, but from where he was bedridden, he moved to his shop, but again, not working. So that was the last experience, sir. Sir, question is used in adolescents.
Yes. We have used ketamine in children, adolescents, adults, even elderly patients. And we found that ketamine, because we are using oral ketamine nowadays, we find it very, very safe. We have used it in adolescents and just ask them to bring 300 ml of juice. We put 2 ml of ketamine and ask them to drink gradually. And it works as good as in other patients. So it can be used in children. In fact, anesthetic agent in children, ketamine is one of the choice. So you can use ketamine in children, you can use it in adolescents, you can use it in elderly also.
So this oral therapy also is a wonderful idea, as sir said, would reduce burden of coming to hospital, waiting, going back, and time also. Sir, there is another question. Preclinical evaluation before ketamine is to be started.
So see, if you are giving IV ketamine, yes, you will have to do all the investigations like we do it for ECT, anesthesia fitness. But if you are giving oral ketamine, no need of any investigations. Unless patient has some major problem, no need for any investigations. See, usual story I will tell you is that it's a Saturday afternoon. You are free half day. You are going for a movie. You have booked a ticket at 3 o'clock. You finish your OPD by 2 o'clock and you are in a hurry to go for the movie. And one MBBS student, usually from the first or second MBBS, comes as a walking towards you. When you are leaving the OPD, when you are in a hurry to go for a movie, and he comes and says, "Sir, can I talk to you?" in a very innocent manner, and you say, "Yes, tell me, I am a little bit in a hurry." He says, "Sir, I have an exam on Monday. Today it's a Saturday, and I'm very depressed, and I feel like putting an end to my life." You are stuck. What do? You can't tell him, "No, no, not today. Come on Monday. I am going for a movie. I have a movie ticket, and I am in a hurry." You are stuck. You say, "Get admitted." He says, "नहीं नहीं, मेरा पढ़ाई करना है. I have an exam on Monday." Now it becomes easy. I call the resident on call. I say, "See, he's our student. He's a very good student. He has admitted. He is in first MBBS. He is not feeling well. He's depressed. He's not willing for admission." So we call one of his friends. We make him sit in the ward, and this resident doctor on call gives him ketamine orally. So we ask him to bring 300 ml of juice. We put 2 ml of ketamine, mix him, and gradually he drinks over a period of 45 minutes. We keep him for observation for 1 or 2 hours. And he says, yes, I'm fine. My suicidal ideations have gone. We start him on antidepressants. He goes and appears in the exam on Monday. And then after the exam, we continue ketamine therapy. So ketamine therapy can be safely given in children and adolescents. And we are using it regularly.
Another question is about indication in psychotic depression.
Yeah, this is little tricky question because ketamine itself can cause little psychotic kind of symptoms, dissociative state, what we call. So if the patient has psychotic symptoms in treatment-resistant depression, we usually give combination of antipsychotic with antidepressant, and we encourage him for ECT rather than ketamine. Because ketamine, I think, can aggravate psychotic symptoms. So we are little reluctant to start ketamine in patients with psychotic symptoms, unless the symptoms are mood congruent, psychotic symptoms, then under cover of antipsychotic. So patient is on escitalopram, olanzapine, and then you can try ketamine. And if there is a improvement, well and good, but keep watch for psychotic symptoms. There are a few people who have tried lamotrigine. So you give lamotrigine and then ketamine to prevent psychotic symptoms. But I'm not very sure of that thing, and we have not tried it.
So the abuse potential of ketamine.
Okay, so we are using ketamine for more than 25 years, and not a single case report of ketamine abuse where it has been used for therapeutic purpose, particularly in patients. Ketamine, we all know, is a street drug, and many people may be addicted, may be abusing, but the patients in whom it has been used, none of them have become addicted to ketamine. Another question which people ask me that for how long you can continue, and I have a patient, he's a resident in neurology, and he had severe depression, multiple suicidal attempts, and he was not able to attend his neurology rounds, clinics, though he was registered for post-graduation in neurology. And lots of other problems he had at home. We started him on oral ketamine. He is now taking oral ketamine every day for last 6 months. And he's absolutely fine. After about 1 month, he improved to such an extent that he started going for his round. He started attending OPD, started attending clinics, ward rounds, everything. He has resumed his studies. And now he says whenever he takes ketamine, he is much better. So he's trying to reduce the frequency of ketamine administration. And initially he noted that he used to take it in the morning, and then he used to feel a little sleepy throughout the day because ketamine is an anesthetic agent. So now what he does, he wakes up at 4 o'clock in the morning, drinks 300 ml of juice with ketamine, goes back to sleep, wakes up at 7 again, and goes and works. And this is how his depression is maintained. Initially, he was taking every day. Now he is taking 3 times a week. Then gradually, he's going to reduce it to twice a week, once a week, and stop it. But you can give ketamine even for a longer duration of time, longer period of time.
There is another question, sir. We need to continue whether ketamine while the patients are on whether there is a need to continue antidepressants.
Yes.
If we are doing ketamine therapy.
Yes, antidepressant must be continued. See, the NMDA system, the NMDA receptors and MPA receptors are like the deans of the college. They have an inhibitory effect on serotonergic system, dopaminergic system, norepinephrinergic system. So they have a basically inhibitory effect. And that's why your antidepressants are not working. Now you block NMDA and potentiates MPA receptors, this inhibition is removed, and your antidepressants will start working. So that's why you must continue antidepressants, because you have kind of managed the dean. Dean has given the permission to the the lower departments like psychiatry department that yes, you continue. So now that inhibition is removed, so that antidepressants will start working in serotonergic system. So antidepressant must be continued when you are giving ketamine and even after giving ketamine.
Pregnancy, its use in pregnancy and whether it is teratogenic.
No reports, no trials, nothing, but to the best of my knowledge, it is absolutely safe giving ketamine in pregnancy, and all antidepressants are safe. If the patients ask me, I say we have no data, but our practical experiences show that it is very safe. Practical experience of using antidepressants in pregnant women, it shows that less than 5% risk of any kind of teratogenicity or any kind of side effects, less than 5%. 95% safe, 5% risk, which you can take while walking on the road also. But if you stop antidepressants because of the pregnancy, 95% risk of relapse. You can develop depression, and then pregnancy you will suffer. So it is better to continue antidepressants, and if you are taking ketamine during pregnancy, do the regular sonography to see the development of the child. And if everything goes fine, you go ahead. Between 11 to 16 weeks, when you do the sonography and you find there is some major malformation, you have an option of medical termination of pregnancy.
Sir, another question is about its using patients with comorbid conditions, like especially hypertension, or are there any contraindications?
See, ketamine can cause a little increase in blood pressure, increase in pulse rate when you are giving or when you are drinking ketamine. That's why we monitor the pulse and blood pressure. And if you feel that blood pressure is going high, stop the infusion. But if the patient is well maintained on antihypertensive medication, and during ketamine sessions, when he is drinking ketamine, his blood pressure remains normal, nothing to worry. So if he is drinking ketamine, monitor the blood pressure at every 15 minutes. And if you find that blood pressure is increasing, you can stop the ketamine drinking, or you can further slow down the ketamine drinking. So instead of 40 minutes, 45 minutes, ask him to drink it over a period of 1 hour and monitor blood pressure, and if necessary, give antihypertensive medicines.
Sir, there is interest about its oral use, whether it can be taken with water or drinks, and also concern about how it can be prescribed for oral use at home. How does the patient procure?
We give 3 prescriptions in India, in Maharashtra and in Bombay. We give ketamine, injection ketamine, 2 ml vial, 5 ml vial, or 10 ml vial, prescription in triplicate with doctor's stamp. And patients go with that triplicate prescription to the medical store, and patient can get the ketamine injection. After the patient gets the ketamine injection, we do first 2 or 3 times in the OPD in front of the patient's relatives and teach the relatives how to give ketamine. So we ask them, they can take it either in water, it becomes little bitter and kadu. So then they may not like it, but if they want, they can drink it in water. Or we say better it is in the juice, so the taste is masked. So we ask them to bring 300 ml of juice, put 2 ml of ketamine and drink it gradually. And we teach patients' relatives to measure the pulse and blood pressure. Pulse oximeter has become very, very popular after COVID. Everybody has pulse oximeter at their home where they can monitor the pulse rate. And also we teach them to monitor blood pressure with automatic BP measuring instrument. And then we tell them to take it at home. And if they have any difficulty, they can contact us in emergency. So it can be done at home. You can give them ketamine at home, and the same procedure which you are doing in the OPD, they can continue to do it at home.
Can it be discontinued, or how it is to be discontinued? That must be the question.
No gradual discontinuation is required. You can stop suddenly, you can stop whenever you want. But usually we do it the way we kind of reduce other medicines. we also do the same thing for ketamine. 3 in the first 2 weeks, then 2 for next 2 weeks, and 1 for next 2 weeks, and then discontinue. But there is no need. If somebody is better and stops ketamine, there are no withdrawal symptoms.
Has there been any medico-legal experience? I think 3 prescriptions will be important. Apart from that, sir?
Not so far. But yes, we take proper precautions. We tell the patients that this is not a usual treatment. This is used only in treatment-resistant depression. There are some side effects, rare side effects. One of the very, very rare side effects is increase in intracranial pressure. So if the patient complains of sudden headache or something, you stop ketamine infusion or oral ketamine. But we must have given so many ketamine by now, but we have not noticed this kind of side effects. But we tell the patients that they are extremely rare, and majority of the patients have used it. Initially, we do it in front of us in our outpatient department. Patients feel that yes, it is safe. He's happy with it. Relatives feel confident. Then only we ask them to take it at home. So all the precautions must be taken for ketamine therapy.
Sir, I think we have reached all the questions, read out all the questions, and if I remember that it is resistant depression, and it is about suicidal ideas. The thing is, it is an antidote, and I would request Dr. Rashmin Kolra, sir. Thank you for providing an opportunity to listen to sir. Over to you, sir. Dr. Rashmin.
Can I add one more thing?
Yes, sir. Yes, sir.
Please.
Yeah, nowadays we are also using in pain disorder. And recently, this was a patient who had intellectual disability with severe headache. And he was not able to speak. He was not able to do anything. And he would just keep on saying something that he's having some unusual sensations in the head, to the extent that he would start banging his head. And he had gone to pediatric department, medical department, neurology department. People had extensively investigated him, and everybody said that he is intellectually disabled. He has some kind of headache in the head, but we are not able to find out the cause of headache. But all other parameters, CT scan, MRI, everything was normal, no papilledema. We started giving him ketamine for pain relief. And remarkable improvement. The relatives were so happy. They said, this patient, our own child, intellectually disabled, not able to tell anything. He was banging his head, and we could make out that he has severe headache. And after ketamine course, total recovery from that headache. And similarly, we had treated 1 or 2 severe cancer patients who had severe pain, and everybody had given up. Morphine did not work. Other painkillers did not work, and where ketamine worked to the extent 50, 60, 70% reduction in pain, and their pain became little bearable. And Dr. Ketan Parmar, one of the colleagues, is using it in pain control for opioid withdrawal. Because when you stop opium, you get severe withdrawal, and one of the symptoms is severe body ache. And that is one of the reasons for relapse. And he has been regularly using this ketamine IV or oral in patients who complain of severe body ache and pain after stopping brown sugar or any other kind of opioids. So we are also now expanding the indications for use of ketamine. Thank you very much.
Thank you, sir. A couple of people have been asking a few questions repeatedly. Dr. Purva wanted to know if the patient has regular antidepressants for the past 4 to 5 years in remission and absolutely fine, but discontinuing them causes a relapse, and if he asks us whether his depression will be cured with ketamine therapy, and can his antidepressants stop entirely? What do you have to say, sir?
Yeah. So antidepressant must be continued. Ketamine can help if it's a treatment-resistant depression. But ketamine is not a cure where you give ketamine and once and for lifetime, you don't have to give antidepressant. Probably this kind of effect has been seen by psilocybin. I'm trying to find out the next molecule, psilocybin, the magic mushroom. If I can get my hands on that, and if I'm allowed to do some experiments with that, there are case reports where only 2 doses of psilocybin, first dose 25 milligram, second dose 100 milligram, and depression is cured forever without antidepressant. I don't know how and why, but there are published case reports. People have reported this. Unfortunately, if I use psilocybin, I'll be behind the bars
Yes.
because it's a illegal drug and it is not
So
available.
far, yes.
But this kind of thing are coming up, and I think someday even psilocybin or similar drugs will come up as an antidepressant therapy.
Correct. Another gentleman also wanted to know if you require to take a consent to administer ketamine.
Yes.
Yes.
We take informed consent, always take informed consent, explain the procedure, explain that it has its pros and cons. It can cause little side effects like dissociation, increase in pulse rate, increase in blood pressure. We will gradually monitor it, and there is a high success rate. You mention everything, give their consent, take them in confidence, and only if they are willing, do this therapy. Never force them to take this therapy.
If I may be permitted to ask you a question, Nilesh bhai, what is the mechanism of action which you think was responsible for the relief of pain in the case that you mentioned?
Yeah, ketamine is an anesthetic agent, and again, either NMDA receptor antagonist or AMPA receptor, because see, what we are using is racemic ketamine. And in racemic ketamine, S-ketamine has more effect on NMDA receptors, and R-ketamine has more effect on AMPA receptors. So I think both of them are acting at present. They have separated and they have found that at least for depression, it is R-ketamine which is more important, the potentiation of AMPA receptors. So I think if somebody does this kind of study for pain patients, because people are not using it for pain the way we are using it nowadays. So I did not find many studies and many research on pain. But yes, somebody will try to find out whether it's R-ketamine, S-ketamine, or combination of both.
Correct. In fact, in North America, they use ketamine a lot for pain management for terminally ill patients. That is one of the biggest indications. They don't use it as much for alleviation of suicidal ideas and depression as they do for pain management, actually. Right. Excellent. Thank you so much. And it's been an absolute pleasure to listen to you, Dr. Nilesh Shah. You have, as usual, always been as simple and lucid in your communication and your presentation, as clear and as enlightening as your conversations and your discourses are. So we are really delighted to have you back with us, and we were really happy to have to listen to your talk today. Thank you very much, sir, for making the time. I know you have a very busy schedule and you have a lot of obligations at Sion Hospital as well as your other teaching obligations. Dr. Tiwari, thank you very much once again for making the time, and you are on our platform for the first time, but we hope to have you back sometime soon. And of course, to all the participants who participated in a very large number today, and also were very enthusiastic and posing really interesting questions. We hope that this lecture series has been helping you as much as it is a pleasure for us to bring it to you. And thank you, Sun Pharma, for your unflinching support to our activities. We promise to bring you many such interesting talks going forward. But it was a delightful evening, and I thank you all for being with us today. And I wish you a good evening ahead. Thank you very much once again, Dr. Nilesh Shah and Dr. Tiwari. And thank you all. Have a great evening ahead.
Good evening and good day.
Thank you.